you to be able to actually call it secondary hypertension to alcohol, this is some studies have shown that you need to be drinking at least like 20 to 30 servings per week. That's a lot. That's probably how much? 4 drinks? So 4 drinks per day? Most patients don't do that. I mean, let me take that back. If you work at a county, like I work at Olive View, this is quite common. We have so many alcoholics over there, but like generally speaking, most patients don't drink 4 servings per day.
So I had a patient last week.
Yeah.
And he had CHF, pretty young guy, fairly healthy looking guy. And when you dug deeper into his history, and he's like, yeah, I take my antihypertensive drugs, whatever, and he's in this acute CHF exacerbation. He tells you that he's doing cocaine a couple times a week, going back to what he said.
Incredible.
And additionally, he's drinking a pint of vodka every other day.
Incredible.
And the blood pressure, even though we're treating him not with hydralazine and treating him, it's still refractory to.
Yeah, and you're not supposed to give, like, only if it's cocaine induced, you're not supposed to give just beta blockers. Remember, we talked about that? Because patients can have unopposed effect, alpha effect, and can become more hypertensive. Yeah, so for your interviews, if they ask you what is the single most important health problem in the United States, it's just like this kind of stuff: obesity, alcohol consumption, drugs. It's not even about like diabetes. These are like secondary to lifestyles, and you realize like how poor your patients live. I have 170 dialysis patients, and every time I get a new patient, I think about what is it that this guy did wrong to end up here. And I'm going to tell you that the vast majority of patients, I'm talking about probably like more than 90% of them, are there because they weren't listening. They developed like self-inflicted diseases, like I call, and a few of them developed like GNs that you can't really do anything about that. But that the way we eat, the way people take care of their bodies in this country, it's just terrible. They don't take care of themselves. Yeah. So teaching point is a lot of alcohol, not just a little bit of alcohol. Okay. So he snores, denies any hypersomnolence or headaches. Those two are very common review systems for sleep apnea patients. And you ask the partner, you don't ask the patient if they snore or they stop breathing, you ask the partner. And he's obese, his BMI is greater than 35. So chances are that you probably have, if you're obese, you have a very good chance that it's like a 50 to 90% that, I'm sorry, if you're obese and you have hypertension, your pretest probability that you have sleep apnea is pretty high. So these are the symptoms, usually the gasping, choking, hypertension, obesity, snoring. But when we use the physician impression, like you can have like 50% of the times they can be wrong. But the interesting thing is that the prevalence of sleep apnea is pretty high in resistant hypertension. Like these are 2 series from Lozano and Logan, and both like in the 80s. But what I found very disappointing is that when you treat these patients, don't put all your money in treating the sleep apnea, because the hypertension response is pretty negligible. It's like 3 to 5 points reduction in the systolic blood pressure. That doesn't mean you shouldn't diagnose or treat the sleep apnea, because both this condition has significant morbidity and mortality. It can carry decreased quality of life, car accidents, pulmonary hypertension, right heart failure from core pulmonary, increased risk of strokes, so atrial arrhythmias. So the evidence is overwhelming towards like treating it. But the teaching point, the take-home message is that even if you're treating it, that doesn't mean you're going to fix the problems, the patient's blood pressure problem. But everybody should get treated. Can you help me read this one? Yeah, you can go.
You refer him for polysomnography, demonstrating an apnea-hypoapnea index of 20 events per hour, moderate OSA. He begins CPAP and is now seeing you 2 months later. He uses CPAP nightly, sleeps well, and says that he feels more energetic. He still takes lisinopril, chlorthalidone, amlodipine, and metoprolol. His exam is unchanged, and his blood pressure is now 157/88 instead of 160/90. Which one of the following is most likely to result in control of his hypertension?
Go ahead.
Spirulactone, 25 milligrams a day, titrating to 100 milligrams a day as needed. An exercise program of walking 20 minutes 3 times per week. C, referral back to the sleep apnea clinic to adjust his CPAP mask or prescription since the therapy is not working. Referral to ENT for laser-assisted vulvoplasty. E, long-acting diltiazem,
Diltiazem.
120 milligrams per
A day?
per day. Titrating to 300 milligrams a day as needed.
This is a calcium channel blocker. So what do you think is the right answer?
B.
B? Listen, boy. So what is the American Heart Association statement about daily exercise?
That you should have, I think it's like at least 30 minutes.
Right, and it's daily.
Yeah.
So this B is incorrect because what I'm presenting you there is 20 minutes 3 times a week. So
I thought we just said, incremental goals. Hey, you're not doing anything. Let's try 20 minutes.
but we're dealing with a hardcore patient already because he's taking lisinopril, chlorthalidone, amlodipine, and metoprolol. He's still not controlled, and he's taking care of the sleep apnea is taken care of, and he's still not controlled. So it's spironolactone. So if you take a look at the guideline I gave you guys, so I'm the physician champion in my medical center for hypertension committee, and I've been in conversations with the regional leadership to change this protocol because they're giving the doctors the option of either adding a spironolactone or a beta blocker. I disagree with it. I think that the fourth drug should always be spironolactone unless you have a contraindication for spironolactone use, which are, you guys remember? Sorry? If you have severe hyperkalemia for, like advanced kidney disease, for you guys, if you want to adhere to the guideline, if the GFR is greater than 60, you can use it. Make sure you document that the patients were formally educated about low potassium diet. Which foods contain a lot of potassium? Phosphorus. That's phosphorus mostly. What else?
Apples have a lot.
Apples is actually one of the few things that dialysis patients can eat. Apples and pears. But the green leafy vegetables, they also have a lot of potassium, like spinach, unfortunately, has a lot of potassium.
Broccoli,
Broccoli has potassium.
asparagus.
Less. So the highest, just so you guys so you know, orange juice has a lot. Coconut water has a lot. Like somebody taking these medicines should stay away from coconut water. Or dialysis patient is almost like a lethal injection. If you drink a liter of that, you're gonna code. Like they just called me from the ER patient with potassium of 7.8. Yeah. So the avocados are quite common in our Californian diet, and they contain a lot of potassium. Seaweed has a lot of potassium. Molasses has a lot of potassium. Some cultures like India and Nepal, they eat a lot of molasses. So you need to address for those things. Nuts have a lot of potassium. Potatoes, tomatoes, beans. So you teach the patients to do what we call the double soaking technique. So you just soak them, you get rid of the water, you let it rest overnight, get rid of the water, and then you cook them again and you get rid of the water, you put more water. That helps reduce the potassium. Fresh pineapple has a lot of potassium. Canned pineapple has less potassium, so you recommend to do your patients to do canned pineapple. But like kidney diet sucks. The reality is, like, when you realize like all these limitations you need to get rid of, all this delicious food that I mentioned is very hard. But you need to know this by heart, because that's how you're going to be counseling your patients. If somebody's already on an ACE inhibitor and you're going to be adding spironolactone, they need to know about these things, because the risk of hyperkalemia is much higher. And the foods that are usually okay for advanced kidney disease or dialysis patients are apples, pears, grapes. And remember, it's not just the choice, but the quantity. I have a patient who was very cute, like he was only eating grapes, and I asked him how many, like, well, that's the only one I can eat, so I was eating it throughout the day. Like, well, it's not only a choice, but the quantity, right? So, right. So, yeah. So for your documentation, you're starting the patient with spironolactone in addition to even a chlorthalidone or lisinopril, like this person. So the next drug will be spironolactone. You need to provide the patient with low potassium medication. I'm fortunate to have a renal dietitian in my team, so I can refer my patients for formal potassium education, and they teach them, okay, we're going to try to keep your potassium intake less than 2,000 milliequivalents per day, same as sodium. It's easy to remember because it's the same recommendation as sodium. And you can start up titrating spironolactone. Remember, for spironolactone titration, you need to have baseline labs, and you need to have labs about a week after you change the dose or you start the medication. And it's very effective.
What's their limitation of phosphorus intake?
Phosphorus is for advanced kidney disease. So, phosphorus for your boards, it's an independent risk factor for cardiovascular mortality, and it's a very, very important goal that we need to attain for all of our patients, because it's a mineral and it's only excreted by the kidneys under the influence of PTH. And that's part of the reason why the physiopathology is like when you start losing your nephrons, your phosphorus excretion goes down and the PTH production goes up. That's what we call secondary hyperparathyroidism. So once it gets absorbed, you can't poop it out, you can't sweat it out, and it goes straight and deposits into the arteries. That's the reason why on your boards you need to know that it's increasingly more and more recognized as an independent risk factor for cardiovascular morbidity and mortality. The recommendation from the National Kidney Foundation is that we keep our patients with a phosphorus of less than 5.0. The foods that are high in phosphorus, do you guys know? Organ meats, yeah. Processed foods, like it's a preservative. Yeah, like everything that's processed has a lot of phosphorus. Deli has a lot of phosphorus.
Even if you give them binders, is that just a temporizing thing? Or
right. Well,
in between dialysis?
Invariably, even if you give them binders, invariably you're gonna have to be on a phosphorus restricted diet, because most dialysis patients, they stop peeing, and when that happens, they are 100% dependent on how much you're able to bind in the gut, so it doesn't get absorbed. But it's almost like you need to be on a low phosphorus. From the dialysis unit rounds, which patients are following a low phosphorus diet and which ones are not. No matter what they tell you, you already know. It's like one of those things that you see a patient on Lipitor 80 and my LDL is 200. There's no such a thing unless you actually have like one of those familial hyperlipidemia syndromes. So in the dialysis units, we always restrict the phosphorus intake to our patients, and one of the most common phosphorus foods are milk and dairy products, which kind of like a lot of people eat, like either ice cream or milk or cheese. So imagine if I remove all of these delicious things that I just mentioned, life is not fun. So, but phosphorus is a very important therapeutic goal for our dialysis patients. So peanuts, nuts have a lot of phosphorus, beans have a lot of phosphorus, but mostly dairy and dark sodas. Dialysis patients should never have dark sodas, should never. They have an incredible amount of phosphorus in it.
So that's like Diet Coke?
Yeah, they need to have a Sprite. I don't recommend any sodas, but if you want to drink a soda, just have they can only have root beer or light, like Sprite or 7-Up or whatever. Okay, so these are the slides that I was just telling you, like this is the effect of CPAP on blood pressure. It's pretty disappointing, right?
Yeah.
But the take-home message is you treat it regardless, okay? So these are some of the studies supporting the use of spironolactone as the fourth drug in resistant hypertension. So this is the Ascot Trial. It's a good population sample. It's almost 20,000 people. And they randomized the groups to fourth drug, which was spironolactone, versus some other drug. And the results were impressive with systolic blood pressure reduction of almost like 22 points in the spironolactone arm. And there's another trial that I like it. It's a much smaller sample, but I like it because it was done with the ambulatory blood pressure monitor, which is the gold standard for hypertension. And they look into 8 weeks. They randomize the groups to 2 groups again. And the results were pretty similar to the Ascot trial. This is the Aspiring trial. And the reduction was 10 points on the 24-hour systolic. And almost like another 10 points in the 7 points in the office systolic blood pressure. So again, all data supports the use of spironolactone as the 4th drug. Okay, so I think that the reality is that if you're gonna practice, it depends. This slide is a little controversial because I'm gonna talk about what JNC8 says and what you do in your practice depending on where you end up practicing. Because I practice in nephrology, I always use ACE inhibitors as the first line because I believe in the power of ACE inhibitors, and it's one of the few weapons that I have as a nephrologist. They haven't been able to come up with anything better in the last 20 years. So I always use them. But if you're talking about like a general population person came to your office, normal renal function, no heart disease, so the JNC8 recommends the use of either a thiazide diuretic versus calcium channel blocker, non-dihydropyramide like amlodipine. If you take a look at your little hypertension guideline, so in Kaiser they actually have a combination of ACE inhibitor and a thiazide, and they start them on that as the starting drug. I personally, in my practice, I like to start one medicine at a time because it's basically the risk of side effects is less, and I usually use a thiazide diuretic. What are the requirements for a thiazide diuretic, guys? You guys know if you're going to prescribe it?
Probably potassium higher than something under.
But you need to have what? Labs, right?
Yeah, because side effects is like hyperuricemia.
Which one is very serious? You can kill someone. Tell them. Hey, Dr. Lopez. Hey, how are you?